Welcome everyone to the first online live pharmacy medication instructional program hosted by Mendel's Clinical Pharmacy. Before we get started, I'm going to read this disclaimer that you see on the screen. The PharmAssist virtual learning experience brought to you by Mendel's Clinical Pharmacy is intended only as an educational program for patients. Any clinic-specific information shared by the nurses is the opinion of the nurse and is not intended to replace the recommendation or request of your healthcare professionals. All medications will be dispensed by Mendel's Clinical Pharmacy according to the prescription as written by the provider. Thanks again and welcome everyone. And this is an educational program created by Mendel's Clinical Pharmacy to bring you together with outstanding healthcare professionals right from the comfort of your own home. PharmAssist takes place every Monday at 7 p.m. Eastern Standard Time. Tonight we'll be providing a live medicational instructional program on 3 fertility products, which are going to be Menipure, Ovulation, and Progesterone and oil, including interactive question and answers throughout the program. Please join us via Zoom or Facebook Live, and we invite you to be a part of the discussion by sharing your questions in either format. We are joined by various amazing healthcare professionals each week from across the nation to provide you with real-world experience, just as if you were sitting across from them at the table. Today, we are joined by Kaitlyn Endicott, and thank you again for your time and interest, and now I'm going to turn it over to Kaitlyn.
Thank you, Morgan. Hello, everyone. Welcome to the PharmAssist tonight. My name is Kaitlyn. I'm a nurse practitioner in the Northern Virginia area. I hope that tonight's videos help you to understand and gain confidence with injections and the medications that we'll be reviewing. Tonight, we do have 3 on the books, so we'll start with Menipure and then review Ovulation and then finish the night with Progesterone and oil. After each video, we will have time for a Q&A session, so you can type in any questions that come to mind while we are reviewing the videos. Please do keep in mind that I'm happy to answer any general questions about the medications and the products, but I am unable to answer any specific questions such as why you're on a certain dose of any given medication. Those types of questions I will defer to your provider, as they are the best suited to answer those for you based on your health history. With no further ado, I think we're ready to get started with our first medication, which I believe is Menipure. So I will kick it over to you, Morgan. In this video, I'm going to go over how to do a Menipure injection. First and foremost, I always say to collect all of the supplies you're going to need. That way everything is laid out in front of you and it's ready to grab and go. So for a Menipure injection, depending on your dose, will depend on how many of the powder vials you're going to need. So when you get your Menipure in the box, you're going to have little vials that have powder in them. Each powder vial is 75 units of medication. So I have patients on as low as 75 or maybe half of that, all the way up to 300 units. So depending on what your dose is going to be how many vials you gather. So for today, I am going to do 2 powder vials. That way I can show you how to mix multiple vials. This would be the equivalent of 150 units. So I have 2 of those, and then 1 vial of saline. No matter how many vials of Menipure that you are prescribed on, you only ever need 1 vial of saline. You're never going to have multiple vials of saline. So most patients, if you're on more than 1 powder vial for your dose, you're actually going to have a bunch of saline left over. That's completely normal. Then you want to gather your 3 ml syringe, and this just comes out of the little container like this. You also want to grab an alcohol pad to cleanse the skin. You will also need a Q cap. It looks like this. It'll come in a box with, I think, 5 or 6 of them, so you'll need one of these. And then finally, you'll need a needle for injection. Here I have a 27 gauge 1/2 inch needle, but you can also do like a 1/2 inch 30 gauge, that's fine too. So after that, I usually line up all my vials and take all the caps off. So these just come off like that. So take all the caps off of the powder and your saline. Then you want to peel back on your Q cap. There's a paper here. this peels back and comes off completely. Now your Q cap is actually in the plastic, and you want to leave it in there. This part is sharp, so you don't want to prick your finger on there. Then you're going to grab your saline vial, and this will actually press into the rubber of the stopper into your saline. Then you can take off the plastic piece, and that's just trash. And now your Q cap is on to your saline vial. Then you want to take your 3 ml syringe. I usually recommend pulling back the amount of air that you actually want to end up pulling water out of the vial. So for Menipure, you only really ever need 1 ml of the saline to mix your vials. So pull back until you can see there my stoppers at the 1. Then you're going to take your saline with your Q cap, and this syringe is just going to twist on, so it'll be attached. Then you're going to flip it over, push your plunger up so that the air goes into the vial. Then when you let go, it's going to kind of naturally pull water back. When that happens, sometimes you can get a little bit of air in the top, and I'm not sure if you can see it there. If that happens, just push everything back up and then restart and pull back until your plunger is at the 1 and you have 1 ml of saline in your syringe. At this point, we want to get this water into our powder vials. So we need to take our Q cap with us. What I mean by that is you're going to take one hand on your saline vial, the other on the Q cap, and it actually just snaps like this so that your Q cap is still attached to your syringe. Then you are going to place it onto one of your powder vials that goes through the rubber stopper again. Push the saline in. When you push the saline in, you'll actually see the powder dissolve almost instantly. Some patients like to kind of give it a little bit of a swirl around for good measure. Totally fine. Once you have pushed that saline in, then you're going to want to flip over again and pull back everything out of that vial. Now it's going to be roughly 1 ml because that's what we put in. Sometimes some of the water kind of dissipates when it mixes with the powder, so it might be a little bit less than 1 ml. That's totally fine. Once you pull back all of your saline or your mixed medication out of the vial, this is 75 units. 1 powder vial, 75 units in the syringe. If your dose is 75 units, you're done at this point. You don't need to mix any more, and you'll be ready to put your needle on, so stay tuned for that. But I am going to show how to mix additional Menipure vials just in case your dose is more than 75. So like I said earlier, for this video, I'm going to pretend that my dose is 150 units. So I am going to do the same thing I did before. We need to take our Q cap with us. So take off the empty powder vial, keep your Q cap onto the syringe. You're going to grab your next powder vial that you haven't mixed yet. Same thing. Push your cap on, push your saline in. That powder is going to dissolve. Then you're going to flip over, pull everything back. It's okay if you have some air in it at this point because we're going to prime our needle anyway, so we'll get all of that out of there. Once you have mixed this vial, we do not need our Q cap anymore. We have our dose. Our dose is 150. That's 2 powder vials. We are ready to put our needle on. Now, if your dose is higher than 150, then you're going to want to, at this time, move on to your next powder vial and keep mixing with this same 1 ml of saline. But for this video, we're going to go ahead and get ready to inject. So we do not need our Q cap anymore. Up to this point, we have held here and snapped off here. Now we don't need our Q cap. So we're actually going to twist this off, leaving our syringe by itself. Now, if you accidentally, just from habit moving along, and you take off your Q cap and it's still on your syringe, you can just twist it off and your syringe will be by itself. So now we have our full dose in here. We're ready to inject. So you're going to grab your 1/2 inch needle, This is going to peel like a banana peel. And here is your needle. And this just twists on to your syringe. At this point, I usually recommend priming the needle, which means kind of pushing up on that plunger until all of the air is out, until you see a couple bubbles come out of the top of the needle. Now, in this video, it might be hard to see through the lid that is on the needle, so I'm actually going to take it off to prime it just to show you. But when you're doing it yourself, you can actually see the needle through there. But you are going to push up until you see a few bubbles come out of the top there. Once you see a couple of the droplets come out, you know that you're primed and ready to go. So you can set that aside. Now you want to prep your site for injection. So this is where you're going to take your alcohol pad, pinch an inch of skin in the belly or in the thigh. This is a subcutaneous injection, so anywhere you can pinch an inch of fatty tissue, fair game. I usually recommend doing the belly for these. So you'll take your alcohol pad. This is going to be my skin for today. You'll open it, wipe off the skin, let it dry completely. That'll take away any stinging from the alcohol going in to the skin with the needle. Once it's dry, you can take off your cap, pinch your inch of skin, and you're going to go in fast at 90 degrees like a dart. So 1, 2, 3, and in. Once it's in the skin, you're going to press your plunger until it's completely in. Once it's in, you can take your needle out, get rid of this in your red sharps container, and at that point, you are finished with your injection. Now, depending on how many vials of Menipure you're ordered on, you might find as you're doing it after a couple days and you're mixing the saline that you're getting much less than 1 ml. A lot of my patients that are on 3 of the powder vials notice that they're all the way down to like 0.6 or 0.7 mLs. If that's the case, then you can actually pull back just a little bit more than 1 ml to mix. Like a 1.1 or 1.2, that can help keep the medication diluted throughout the water and less stinging with injection. Key here is to remember, you do not need to do multiple injections for multiple vials of powder, right? We kept mixing that same one over and over. It's like concentrating lemonade in a pitcher. You're not adding more water if you're concentrating it, you're adding more powder. So same amount of water, just more powder vials. I think that's all my tips and tricks for this one. I hope this is helpful, and that's how you will do your Menipure injection.
Awesome. Thanks so much. Okay, so first question is, what day of the cycle do you typically start Menipure? And then usually how long are you on that medication for?
Yes, this is a very good question. So ultimately, this will depend on your protocol and what your clinic has lined out for you. So sometimes it's going to be dependent on your priming method. So whether that be a course of birth control pills that you take before starting injections or estrogen pills or something like that. So, ultimately check with your clinic on this, but usually it's somewhere where your baseline. Okay, so that's where we're usually wanting to start these medications, where we have a nice clean slate to recruit these follicles. So if you're starting with a period, usually that's on day 2 to 4 of your cycle. If you're on birth control pills before, it's usually a couple days after your last pill, somewhere where we know that you are nice and even at a baseline level. And then in terms of how long you'll be on the meds, it really just depends on your body's response to the medications. I would say on average that most patients are on stimulation medications, so Menipure, Gonal F, for 9 to 11 days on average. Now, you can give or take a few days either way, because again, it's going to be based on your response. But that's why we bring you in for those frequent monitoring appointments. So we're watching closely with blood work and ultrasound, seeing how your body is responding so that we can time out the egg retrieval at the perfect time for you. But overall, I would plan to be on them for somewhere between 9 to 11, 9 to 12 days.
Okay, great. And another question that came is this patient is finding that she's bruising a lot with her Menipure, not so much with other medications. Any tips or tricks to help with the bruising?
Hmm. Let's see. It could. So if the other medications are subcutaneous, so in the belly or the outer thigh, and that's the only difference, maybe it's just a little too much liquid that it's causing some irritation underneath. So maybe you could try to pull back maybe just like zero point 0.7 or zero point 0.8 and see if maybe a smaller amount of liquid causes you less irritation. Depending on how long you've been on the Menipure, if it's just been 1 or 2 doses that you've experienced that with, it could just kind of be a fluke and you're just hitting a small vessel and that's what's causing it. But other than that one, I'm not so sure of. Morgan, do you have any tips for that one that you've heard of?
Yeah, I would just say that usually Menipure, I feel like it irritates the skin a little bit more compared to like Gonalef or Follistim or other sub-Q medications. I kind of the same. I would say maybe try a little bit, maybe a little bit more diluent, not a whole lot, or maybe just where the area it's at, and definitely avoiding that where you're bruised at because for until the bruising kind of goes away. But as long as you're not having like a rash or heat or anything like that, I wouldn't be too worried about it, or if it's not like super uncomfortable. But I do hear that Menipure is just a little bit more uncomfortable, and some people just have a little bit more like itchiness or bruising with that for whatever reason.
Perfect. Thank you.
Yeah. Yeah. Another question is with the Menipure, how do you store it? Does it need to be in the fridge? Does it need to be left out? How would you recommend storing the Menipure?
Yeah, so the Menipure is okay to be stored at room temperature. You don't want it in extreme heat, so keep it out of direct sunlight, but just somewhere on the countertop in your medicine cabinet, somewhere that will help you to remember to do it. A big tip when you get your medications and they come in that big box, you're going to notice that some of them are in cold packs, some of them are not. So immediately once you open it up, anything in cold packs, just put it in the refrigerator. It's safe and sound. That's how it needs to be stored. Anything that's not, you can keep it, again, room temperature, wherever works best for you, medicine cabinet, on the counter, whatever's best. But Menipure is room temperature for storage.
Great. And I know you kind of mentioned in your video just the different doses that your doctor might prescribe. Is it normal for your doctor to maybe change your doses throughout the cycle? And if they do, why are they increasing or decreasing the doses?
Yes, good question. So again, this will depend on your clinic, and their protocols and preferences and how they typically run things. But yeah, your dose can absolutely change. So it can be for a number of reasons. Maybe the ovaries are super excited about the medication and really listening and off to a really fast start, and we want to kind of tone it down and bring it back so that it's a nice controlled progression of follicle development. So in that case, we may turn down the dose a little bit, or maybe we're seeing the opposite where we give the medication and the ovaries are kind of like, oh, I don't know about this. And they're kind of sleepy and quiet at the beginning. Maybe in that case, we would want to increase the dose and just start talking to them a little bit louder, see if we can get them to wake up. Another time, though, that I think you see more across the world of fertility treatments is a change in your dose, whether it be Menipure or your FSH, so Gonalef or Follistim, when we start an antagonist medication, so a Cetrotide or a Ganirelix. So we will tack that on really midway through the cycle. Those prevent you from ovulating because we want to keep all the eggs for ourselves at egg retrieval. But because of this action, it can actually slow things down and kind of just tap the brake a little bit. And so because of that, sometimes we combat that with increasing your dose of FSH or Menipure. So you may see that maybe you started off on one vial, but when you started your antagonist medication, your clinic may say, okay, we want to go up to 2 vials, or maybe you started at 2, start antagonist, and they want to go up to 3 and so forth. So I would say that those 3 are the most common reasons why we would adjust that dose along the way. Really good question.
Perfect. I love how you an analogy of talking to your ovaries, either quiet or louder. I think it's a really good one. Other question. So people have been hearing this phrase OHSS. What is that, and what do we be aware of for like signs and symptoms of that, and then possibly what's a treatment for it?
Sure, yes. So OHSS stands for ovarian hyperstimulation. Essentially, through an IVF cycle, our hormones are shooting through the roof. We go to egg retrieval and they plummet back down. Throughout that stimulation, the vessels can actually become permeable, and so fluid shifts can occur. So essentially, the fluid can leak from the vessels, and what this can cause is some uncomfortable feeling for sure and bloating. But really, if that fluid starts to collect, it can impact other organ systems. So it could build up on the abdomen, impact the lungs. So it would depend. The treatment course would depend on how severe, any other organ systems that may be in play there. For example, if the fluid builds up on the belly, that could warrant a paracentesis, so tapping that fluid to drain it. Big signs to look out for with this is trouble breathing, trouble walking, issues with urination, not being able to urinate, trouble speaking. So if you can't get out a full sentence without catching your breath in between words like that, that would certainly be a sign of it. OHSS used to be much more prevalent in IVF treatment compared to now, just due to the medical advances of different trigger options and so forth. So it's certainly not something we see commonly, but it is something that is serious. So if you were to develop any of those symptoms, weight gain, bloating, trouble talking, walking, breathing, that would certainly be, a medical emergency to seek healthcare.
Yeah, great. I would say, like you just said, that it's not as prevalent as when I started, doing this 10 years ago. It's very rare that I see someone have like severe OHSS to where they need to be hospitalized or do anything these days. Okay, one other question that came in, I kind of briefly touched base, but is it okay if the Menipure is in the fridge? I know you say you can leave it out, but if it's in the fridge, is that okay? Or what should they do?
Yeah, I think it's okay to put it in the refrigerator. I think the official recommendation, though, is to keep it at room temperature. Best practice. I think if you've had it in the refrigerator up to this point, it's fine. But I think the official recommendation is to keep it at room temperature. Morgan, you can correct me if that one's not spot on.
No, totally. Yep, I would agree. If it's in the fridge, it's not going to hurt anything, but I would take it out. And also feel like if it's in the fridge, the powder doesn't dissolve as quickly because it's kind of like sometimes like maybe cold. Just take it out of the fridge and then just leave it out, but no harm or no foul done.
Perfect. And the saline, if it's cold and you inject it, might just feel worse than room temperature too. So if you have it at room temperature, you probably won't feel the injection going in as much in terms of the saline, the temperature there. So.
No, yeah, totally agree. Okay, I think that is all the questions. If you don't have anything else, I'll get the next video rolling, which is Ovidrel.
Perfect. Sounds good. Now we're going to review how to do an Ovidrel subcutaneous trigger shot. Now the shot will come in a box that looks like this. It's all pre-filled, ready to go for you. No mixing, the needle's ready. So this is generally just how to do a subcutaneous shot. So you'll need your supplies. You'll need your injection. So you can see it here. You also need your alcohol prep pad, and that's it. So since the shot is ready to go for you, really what you need to do is select your site for injection. Now, subcutaneous injections can be done in multiple places. I would confirm with your healthcare provider where they want you to inject. Generally, I recommend either the abdomen or the thigh tissue. Really anywhere that you can pinch an inch of skin is fair game. I think most of my patients end up doing the abdomen, but it's up to you. So once you have chosen your site, you will open your alcohol prep pad, clean the area, let the alcohol dry, and you will take your injection, take the cap off, and you will see the needle there. Now, if there's a little bit of air in there, you can always press it up to get rid of it. Otherwise, it's pretty much pre-filled for you. Then you will pinch an inch of skin, so that area that you prepped, pinch that inch in fast, 90 degrees like a dart. Press the plunger. Hold it for a few seconds, then remove. this point, this can go straight into your sharps container. No need to recap it to risk sticking yourself. And you've completed your Ovulation Trigger injection.
Awesome. Okay, so with Ovidrol, how does it actually work to trigger ovulation?
Yes, very common question we get on PharmAssist, right? We want to know, how to do these medications, but we also want to know why and how they work. All those things are super important. So in a natural menstrual cycle, once we have a dominant follicle for the month, our estrogen level is increased, which causes our brain to say, there must be a mature egg in there. Let's ovulate and attempt for fertilization and pregnancy. And so that causes the LH surge. So our LH, luteinizing hormone, increases, and that causes the egg to leave the follicle. So ovulation. The Ovidrol is HCG, but it works in a similar fashion in that essentially we give a boost of that HCG through the injection that tricks the brain into thinking it's an LH surge because they work on the same receptors. So the brain thinks that ovulation occurred or the LH surge occurred. So ovulation happens. The egg leaves the follicle for attempt for fertilization. So the Ovidrol is essentially just mimicking a natural LH surge.
Great, that was a perfect explanation. I think it's always important to know like the physiology behind the medication to kind of make more sense to us. Next question is, what happens if you take your Ovidrol too early or too late from the time that your doctor or nurse recommended taking it?
Yeah, so, I suppose this will depend on what your treatment plan is. This could have very little effect on your plan, or it could change things tremendously. So once you are instructed to take the Ovidrol, if your clinic is giving you a very specific time to take it for a procedure, then it's super important to be timely with that. So you're going to want to set an alarm or have a sticky note or something that reminds you to do it at that given time. Now, if you accidentally do it too early or too late, be sure to contact your clinic because they may want to move things around depending on what your plan is to meet that. And the reason is once the Ovidrol injection is given, roughly 36 hours later, ovulation is going to occur. So that's usually what they're working with to time out your procedure. So if you give it too early, you may ovulate before. If you give it too late, you may ovulate after a scheduled procedure, if that's the plan for your treatment. And for some procedures, that's certainly fine. But for others, it may change things. So if that happens, I would definitely contact your clinic. If you notice that you missed the time and your clinic has an on-call if they're not open at the time that you were supposed to give it, I would certainly utilize that on-call line. They may or may not want you to actually do it at that point. They may rather see you the next day and see how things are looking and then maybe replan it for the following day if that's an option. So this is something that I usually recommend running by your healthcare team prior to starting your cycles so that if something like this happens, you know what their preferences are for you. If they would rather you just do it when you remember it, fine, that's great. You have a game plan for that. Of course, we don't want it to be too early or too late, but we're humans and things happen. So definitely be in contact with your team and run through these scenarios so that they're able to guide you ahead of time as to how to navigate that. But ultimately, to answer the question, if it's given too early or too late, it just times out ovulation. So depending on what your end goal is, it could impact a procedure.
Perfect. I always tell my patients to set like 5 alarms because it's really important to take it punctual. But like you said, if it, not to panic if it's before or late, just contact your provider and they can adjust things as needed. What happens if Ovidrol doesn't work, or does it work every time? Is it guaranteed to make you ovulate? And what happens if it doesn't?
Yeah, great question. I would say that most times it works. Some clinics will do luteal checks to make sure it works. So maybe they'll test blood work a day or two later, a couple days later, just to make sure that it's working. If it doesn't, maybe you need a higher dose of medication or different trigger depending on what your treatment plan is. There's certainly options for that. I would say that though, 9.9 times out of 10, this works for our patients. So I would, rest assured that if you are checking a few days later and your progesterone's up, that's indicator that you ovulated and it works. That's an option you can ask, your clinic if they would be open to doing, if that is something that you're concerned about with this particular shot and that it may not work. But again, most times this is going to trigger you to ovulate.
I totally agree. I think very, very, very rarely have I seen it not work. I can probably count on one hand how many times I've seen that happen in like 10 years. So
yeah, definitely. I agree.
It's
so rare, which is great.
If you're worried, just ask for blood work. That can definitely verify it either way. So I think it's a great recommendation. Okay, I think that's all the questions I have for Abigail. If you have anything else you want to comment on that, if not, I'll get us rolling for the last video, progesterone oil.
Now I'm going to show you how to do a progesterone and oil intramuscular injection. First, I recommend collecting all the supplies that you need to do the injection. So first and foremost, of course, you need your progesterone and oil medication. So collect that vial. Next, you will need a syringe and needle. Typically, it's a 3 ml syringe that's used. A lot of times they will come with needles attached onto them. For the sake of this video, my practice uses the 22 gauge needle to inject and an 18 gauge needle to mix. I recommend talking to your provider about what they prefer you do for your treatment. So here I have the 3 ml syringe with a 22 gauge 1.5 inch needle. So then I also have a 1 inch 18 gauge needle to mix. You will also need your alcohol prep pad. So at this point, go ahead and take the cap off of your progesterone and oil. It just snaps off here. You'll see the rubber stopper on top. Then open up your syringe that has the needle attached. It'll peel open like a banana peel. And then you can open up your needle that you'll use to mix. Now, if your provider wants you to use the same needle to mix and administer, you won't need to do this step. So that second needle opens up like a banana peel as well. I recommend avoiding touching the top of this cap here and keeping that sterile. Then if you twist, your other needle will come off. You can set that down to use later. Then this needle will twist on. If you twist to the right, then you can remove the cap. And again, at my practice, we typically have doses of 1 ml. So for the sake of the video, that's what I'm going to use, but I would confirm this with your healthcare provider. So I recommend drawing back to the number that you will use to administer. And what I mean by that is if I'm using 1 ml, I'm drawing back right now 1 ml of air. So you can see my plunger is right at that 1 ml mark. Then you will take your vial and the needle goes right into that rubber stopper. Then push your air in, flip the vial over, pull your needle down slightly to be sure it's in the liquid and pull back, and you'll see the medication pull back into your syringe. And it is oil, so it's a little thicker, so it might take a little bit of help of you pulling down on the syringe. Now, if you have some air, that's okay. You can push back up and start over. That's perfectly fine. So like I said, I'm using 1 ml for this video, so I have 1 ml of the oil here. Take this out. So now I'm ready to administer. I do not recommend administering an intramuscular injection with an 18 gauge needle, which is why I saved my 22 gauge needle here. So this will twist off, put it directly into your sharp spin. No need to recap it. And you'll twist on your needle to inject. So now we are ready. It's time to prep our injection site. For the sake of the video, this is going to be my skin and my muscle. When you're doing it at home, I would confirm with your healthcare provider if they have a preference of a site for intramuscular injections. I typically recommend using the upper outer quadrant of the buttocks, so it's almost like your hip area to do the injection. So once you have chosen your injection site, open your alcohol prep pad, clean the site with alcohol, let it dry completely. Take the cap off of your syringe, and then you're actually going to kind of pull the skin taut, and then you will inject quickly, fast like a dart at 90 degrees. Fast there, all the way to the hub, and then press the oil in. Now it is thick, so it can take a moment to go in. Typically in skin, it's a little quicker than my cube here. Once the injection is in, you take your needle out. There might be a little bit of oil that comes out of the site, and that's okay. You can just wipe it up with some sterile gauze, and then you can recap your needle, put it into your sharps container. You're done. Now, one thing I like to mention with the progesterone and oil, especially because a lot of times when patients are taking this, it's for extended periods of time, weeks on end. So the oil can actually kind of collect if you're not active and moving after you do the injection. So the worst thing you can do is go back to bed, wake up in the morning, do the injection, go back to bed and let it sit. I recommend massaging the area. You can take like a tennis ball or a lacrosse ball and kind of knead down the area as well. Heat can help disperse the oil as well. Just if you use the heating pad, be very, very careful that you pay attention, only use it for small amounts of time. And then being active, so walking around, going for a walk, things like that can help to disperse the oil into the muscle as well.
Okay, great. You kind of touched base on it just very briefly, but you said you're going to be on progesterone oil for a while. Usually how long, and why are patients having to be on it for so long?
Yeah, great question. So this will depend on your cycle type and when your clinic begins to wean off of progesterone in pregnancy. So I would say usually about 5 to 6 weeks on it in total from the time you would start it before an embryo transfer till the time that you wean off of it. I think that most practices are weaning around 6 to 7 weeks, up to 10. It varies. So that'll probably depend on the practice that you're at, the protocol they have you on. If you are on like another progesterone supplementation, like a vaginal suppository in addition, that could move things around as to when they stop the injection. But ultimately, what we are doing with it is we are bridging the time that that we're waiting for the placenta to take over progesterone production. So in a controlled frozen embryo transfer, we do not have what is called a corpus luteum, which is a follicle that is ovulated that kind of shrinks down and forms what we call a corpus luteum in a natural cycle. That produces progesterone. And if a pregnancy occurs, it's sustained and continues to give off that hormone until the placenta takes over production between 6 to 8 weeks, typically of gestation. So in a controlled transfer cycle, we typically don't have that corpus luteum. So we have to mimic that and provide that hormone. So that's the reasoning for the progesterone and oil. And we have to, again, bridge that gap until the placenta can take over. Progesterone and oil is liquid. Gold is the gold standard. So although there are progesterone pills and vaginal supplements and things like that, this is the best, form of progesterone that you can do to support and sustain a pregnancy. So super important medication.
No, great. It's our golden standard too at our clinic. Now, with the progesterone oil, there are different types. Someone wrote, can you talk about the different types and if there's any recommendation on what type of oil to use?
Yeah, great question. So ultimately, this will depend on what the pharmacy mixes with. So there's sesame, olive oil, different oils that they'll mix with. So usually I would recommend just trying that basic mix first of whatever they're mixing with. If you start to notice some irritation over time, sometimes some little itchy kind of bumps around the injection site can occur after being on it for a little bit. That's normal, but if it certainly becomes bothersome, you can request to have it mixed with ethyl oleate. That's what we typically use for any patients that have allergies to the oil that's mixed with and can't have that option. So sometimes that can be a good option to change it up, and maybe it'll cause a little less irritation. I've had some patients that have really good experience with changing to ethyl oleate and have less irritation. I have some that have a little irritation, they change and it's still there. So there's really no way for us to know for certain. But I would recommend typically just starting with whatever the normal compounding mixture is at the pharmacy. And if you need to change it up to see if it helps with any, side effects of those localized things that pop up, you could try ethyl oleate.
Great. I would say the exact same thing. Now, as far as professional oil, a lot of people are worried about the pain. They hear about how horrible it is. You briefly talked about walking a little bit to help, but any other tips or tricks to help with the discomfort of being on progesterone oil?
Yeah. So anything you can do to increase blood flow, like I said, heat, massage, being active, moving around, depending on how often you're on it. Sometimes it's every day, every other, every couple. You can rotate the sites. So the upper outer quadrant of the buttock, do one side one day, the next side the other, and rotate that way. That gives each side some time to recover from dose to dose. The other thing that I like to recommend too is there's some numbing agents out there. So Sanera patch is a good option that can help to numb the injection site. We actually have a few videos on the PharmAssist page on this product. So if that's something that you would be interested in seeing a little bit more about, you can go check that out after this live session here. But essentially it's just a patch that you put on the injection site about 20 to 30 minutes before you're planning to do the injection. Take it off. It helps numb the area, and that can help with some of the discomfort as well.
Yeah, I think the snare patches are amazing. I've tried one out and did not feel the injection at all. I also tell patients it helps with the heating pad, but also to shower. So after an injection, they take like a warm shower and like really massage the area. That will kind of help break up those knots or those the buildup that can happen, along with everything else like rolling out tennis balls, things like that you kind of already talked about. Now, the last question I have with it, with the professional oil is, what are the differences? You kind of briefly talked about the oil and the insert. Why would a doctor choose one over the other? I know you briefly talked about that, but can you kind of go more detail about it?
Certainly. So, there's pills, progesterone capsules that can be used as a vaginal suppository of sorts. They certainly have a localized absorption and effect in the area there. But ultimately, in a case where we are completely taking over, the hormonal support, the absorption from the progesterone and oil, the intramuscular injection is the best way to get the amounts of progesterone that we need in our system. I think that's our main reason for the progesterone and oil, is that it gives the appropriate levels that we need. I think if you were to try to do like the vaginal inserts in place of that, it would take many, many doses daily to try to mimic that. But ultimately, when you've worked so hard to get those embryos, and I know that these injections are not fun, it really, really is the best way to get yourself the hormones that you need. So sometimes some clinics will use both to help space out the progesterone and oil injections. So maybe you do every other day instead of every day because you incorporate some vaginal suppositories along the way. So sometimes they are used in tandem in that way to help with relief from the injections. So I hope that helps to answer your question.
No, that definitely does for sure. And then just one of the panelists is asking, they're called Synera patches. It's Synera. And you do have to get a prescription for them, but most doctors are more than happy to do that because they're that great. But okay, I think that is all the questions that I see coming in, unless you have anything else to kind of say or end things. I'll kind of close this out.
Sounds great. Thank you.
Okay, perfect. Well, again, just want to thank everyone for joining us. Kaitlyn, thank you so much for all your knowledge and expertise. You are amazing. And thank everyone for joining and all the questions that everyone had. They were great. I do want to remind everyone that all these videos are available along with other videos, for example, like the Synera patch, are available on the Mendel's Clinical Pharmacy page, also on YouTube or Facebook as well. And we also do these PharmAssist virtual learning videos every Monday at 7 p.m. Eastern Standard Time. And every Monday we do a different, 3 different medications. So if you didn't see one that you wanted this week, you can always watch the videos or just join us next week, which we'll be doing it. And please always invite your family and friends. We love doing this and being as interactive as we can. But again, thank you all. I hope everyone has a great night. Best of luck in your cycles. We wish you all the best. And until next Monday, take care.